Today we look at the management of diabetes mellitus in pregnancy. Remember where we are coming from, and in less than 5 minutes as a nutshell, we started by looking at the definition of diabetes mellitus as being an endocrine or metabolic disorder in which there is absolute or relative lack of endogenous insulin. Then we went further to look at the classification. We said that traditionally we've been talking about type 1 and type 2. And in type 1, we are saying there's absolute lack, probably implying that we just need the insulin. And this occurs in juveniles, weight loss, DKA, not much familial association, and so on and so forth, as opposed to the other type, which is type 2, where the insulin is present, but there is insensitivity, there is masking, and also there is some kind of autoimmune distraction. Of course, we talked about associations with HLA, DR3/4, and also the fact that this one takes us more towards HHS. This one, there's weight gain. This one is mostly in adult onset, and so on and so forth. And the chances that it can run in families is much higher. Then for the classification for pregnancy, we said that we generally have pre-existing diabetes mellitus or gestational diabetes mellitus. But we are cognizant of the fact that gestational diabetes mellitus can graduate to become overt and later become pre-existing, most likely type 2 type of diabetes mellitus. Then we did talk about a bit of pathophysiology. We had the funny diagram there where we are trying to link the symptoms and signs of diabetes mellitus to the actual physiology. From there, we talked about, of course, the effects of pregnancy on diabetes mellitus. So one of the things we said is that pregnancy worsens diabetes mellitus for several reasons. Reason number one is that there are some hormones being produced in pregnancy, particularly by the placenta. And top on the list, we talked about human chorionic somatomamotropin, or HCS, also previously called human placental lactogen, which raises the sugar in the mother postprandial, so that that sugar crosses to the baby by facilitated diffusion through the placenta. Other hormones are estrogen, progesterone, cortisol, catecholamines, and so on and so forth. Then we also say that pregnancy may make complications of pregnancy, which were not there, complications of diabetes, to appear. Which are those? We talked about acute complications such as diabetic ketoacidosis. We talked about HHS. We even talked about hypoglycemia. Because of the dehydration which occurs in pregnancy due to hyperemesis, gravidarum, and so on and so forth, or just poor eating kind of situation. Away from that, we also said vascular complications, especially the microvascular ones, like retinopathy, nephropathy, can actually be brought closer when one gets pregnant. I think those were the main issues with regards to what pregnancy does to diabetes mellitus. On the other hand, what are we saying? We are saying that let's look at the effects of diabetes on pregnancy, the other way around. What does the condition do to a growing baby and also to the mother carrying the baby? And basically, in that regard, we are looking at complications. So we looked at fetal complications. And fetal complications, top on the list again in the antepartum phase, we talked about congenital fetal malformations, and we said all the systems are affected. We started with the CNS, we talked about open neural tube defects, such as anencephaly, odosencephaly, spina bifida. Remember, what do you call the combination of hydrocephalus with spina bifida? What condition is that? Anotic heart malformation. Type what? Type 2. Good. We can also go to the musculoskeletal. We looked at caudal regression syndrome or indeed saccharogenesis. CVS, we talked about all kinds of congenital heart diseases, of which we're just from talking about cardiac disease, from ASD, VSD, PDA, to TOF, to truncus arteriosus, which is persistent, to transpositions, all the way to Epstein anomaly, Mulenga, everything. But I said that the most common I've observed is septodefects. Then away from that, we talked about respiratory. Now respiratory, we said there's delayed lung maturity. The lungs don't mature quickly. And the main reason that happens is that if you look at the development of the fetal lungs, they are what are called phospholipids. There are even some kinds of proteins, but we don't want to go in that deep science. But the phospholipids, which are the key components of surfactant, they come in phases. So for instance, you start with phosphatidylinositol, it goes up, peaks, goes down. As it is going down, phosphatidylglycerol comes, peaks, goes down. And then phosphatidylcholine, then sphingomyelin. You see, it comes like in phases. Now, what happens in diabetes mellitus is that one of the phospholipids, particularly phosphatidylglycerol, lags behind. And because of that, even if the baby is growing, the lungs are behind. And one I've seen even with my own 2 eyes, how a 3 kg baby of diabetes mellitus can struggle in neonatal ICU. I've seen it several times. In fact, we've lost a number of babies because of just failing to sustain the breathing after the baby is born, because of the same thing we're talking about. And then we also talked about pulmonary hypoplasia, which is very dangerous. We also talked about, of course, genitourinary system, duplex ureter, polycystic kidneys, or things like that. Then on the GIT, we talked about atresias of all kinds, fistulas of all kinds. And we talked about situs inversus. Remember what situs inversus is? The liver, which is supposed to be on the right, is on the left. The spleen, which is on the left, is supposed to be on the right. And things like that, and many other anomalies. Away from congenital fetal malformations, we talked about IUGR, we talked about macrosomia, we talked about sudden IUFD, which is one of the biggest fears we have. And then we also have fetal distress. Then we go in the intrapartum, baby is big in most cases, and there will be CPD. Postpartum, the baby will have all kinds of electrolyte imbalances, especially on magnesium and potassium. Then you also have hypoglycemia, you also have neonatal jaundice, you also have polycythemia and other problems that will arise after the baby is born, including respiratory distress syndrome, or previously called hyaline membrane disease. Then, on the mother, we said there are medical complications which can be acute or vascular. Acute, we've just talked about them. Vascular ones, we have micro and macrovascular. And I think we have a lecture where we pilot one of those points. Then we also went to say the mother is at risk of infection, the mother is at risk of preeclampsia, and of course, polyhydramnios. Now, away from those antepartum, intrapartum, the mother is at risk of prolonged labor because the baby is big. And the postpartum, 2 problems. In fact, let me say 3. The first problem will be PPH. I don't know if I talked about it, due to the uterine atony. Because if the baby is big, the uterus will become atonic. Number 2, shoulder distortion, because of the unequal distribution of fat in the baby's head and neck region compared to the shoulders. And finally, puerperal sepsis. And first, what the 4th one? Milk production. I think that's why we ended there. Well, management. This black one is writing better. So, now, here I have to take my time because this is the main gist of my presentation. It's management of diabetes mellitus. So, if you look at our outline, we talked about pre-conception. Now, at preconception, what is important is that there must be some linkage. And I think Dr. Songiwe Chidwa, you agree with me that that's what we've been advocating. We need to link babies who are seen by Dr. Msonda, the pediatrician, over to the physician, Dr. Wandama Jr., who seems to be working in the ICT department, then he has to hand over that client or that lady to us. I'm telling you, in the absence of linkage, we are mismanaging our patients. Because decisions should be made at preconception, as you shall see. So, meaning that if a non-diabetic lady goes into, you get the point, goes into becoming pregnant without having undergone a preconceptual workup, there's a lot of things you've missed out. And the damage could actually be irreversible or irreparable at that point. So I don't know what methods we'll be using, whether the clients who are going to the physicians should have a register and then they refer them at the time they reach 18 years or reproductive age, or whether the physicians who have read bigger books can be the ones to even just do this management themselves. Or there will be somebody who will be attached. Say, if Dr. Wandama Jr. is doing a clinic, then I'm invited. I'll just be there waiting. Very mute. Just waiting to talk about the midwifery part. Maybe we need to go into multidisciplinary clinics as we move forward. So that, imagine you had a clinic where there is one from orthopedics, from pediatrics, from one, and then you're looking at the one individual. Everyone will give their kind of expertise, including the nursing and midwifery component. I think that person will have a bigger advantage because different units have attended to them. I've talked much about this because I've been a strong advocate of this for a long, long time now. Now, let's go back to preconception. So, number one, we are saying a couple should come. You need to see them as a couple, not as an individual. The same applies to subfertility. A client comes, no, I've been failing to conceive for the past 5 years. I would always insist that the partner, the spouse, the husband is also present. If I see one individual, I will feel like I've not done justice because no matter how much I will explain to that lady, if she translates the same information to the husband, it will not be taken seriously. In fact, it will be taken with a lot of question marks. But I think if you give an opportunity for both of them to be present, you will even feel that they will go home happy. Now, let's go. The first thing that you do is explain effects of pregnancy on DM and DM on pregnancy in simple terms. You are telling them, Madam, you are a non-diabetic. For childhood, you have been injecting yourself with insulin. Well done. We appreciate your commitment and compliance, both to medication and advice. But at the same time, we have to explain now that you are pregnant, what this pregnancy does to your condition, and what the condition does to both you and the baby you are carrying, or the baby you will carry, because right now they are not yet, she hasn't yet conceived. So she needs to understand, and you have to use simple terms, simple language. Number two, you have to do what is known as HbA1c, which is glycosylated hemoglobin. We all know that glycosylated hemoglobin helps us be able to determine the level of sugar control in the preceding 3 months. Of course, a lot of research and studies are being done. I've seen people are going now towards albumin, they are going towards all kinds of other markers, but I don't think we will run away from HbA1c and how it has helped us over the years. We need to tell them that it should always be less or equal to 4.5% by the time they consider having a baby. If it's more than that, again, numbers, it depends on your authority. But let's assume it reaches 9.5% and above, do not conceive. If the lady conceives above 9.5% glycosylated hemoglobin, what will happen? Those horrible congenital malformations will follow the baby. It's as simple as that. So you don't encourage them to conceive. Next, they need to do what is called target organ damage screen. you know that diabetes mellitus, just like hypertension, targets organs to go for this, to go for that. So why can't you screen? What do we mean by screening? We can start by doing retinoscopy or fundoscopy. You check for the eyes. We talked about the diabetic retinopathy. We also have to do ECG, echo, cardiography. Then we also have to do renal function tests, serum creatinine, urea, and finally you also have to do a lipid profile so that you check the levels of LDH and the other lipid parameter, serum cholesterol, and so on. So this should be your baseline. Do you know what we mean by baseline? It's like you want to see what is the situation before pregnancy, so that once she gets pregnant, you're able to follow up and compare and contrast. Next, you are going to give advice on the medication. So the first advice you're going to give is that there will be a possible and likely switch from oral hypoglycemics. Which are the oral hypoglycemics? There are some people who are on glibenclamide, which is Dawanil. There are people who are on metformin. We know that glibenclamide is a sulfonylurea, whereas metformin is a biguanide. There are even some other oral hypoglycemics. Has anyone heard of a class of drugs known as the thiazolidinediones? Thiazolidinediones or the glitazones. That's the nickname. Yes, so if they are on these drugs, tell them that these drugs are too weak to work in a pregnancy situation, so we need to switch you to insulin. Because there are some diabetic clients who are just scared of insulin. Even when these oral hypoglycemics are failing, you tell them we need to go for insulin, they will refuse, say, no, I don't want injection. But I've seen that most of them, when you do proper counseling, once they start insulin, they'll even refuse to move out of insulin. Yes, because they even feel the effects. You know, part of the symptoms of diabetes mellitus is what? Is weakness, because your sugar levels are low. Once you start injecting yourself with insulin, you even feel the energy comes back. Those polyuria things, polydipsia, markedly stops. And they start gaining back their weight. And they just start living a normal life. So I'm speaking as if I'm a strong advocate of insulin, right? Yes. Now, away from this, you tell them this will be switched to insulin. The next is that you tell them that if they were previously on insulin, then the dose will be adjusted upwards. In obstetrics, and we use high doses of insulin. The doses of insulin we use are not comparable to what our colleagues, the physicians, use. Yes, because for us, we are fighting hormones. We also have to save the baby and have the mother live a normal life. So the dose requirements are very high in pregnancy. And that explains, as you shall see, that once you deliver, you stop the insulin immediately. Immediately. Because those doses are too high. They'll push the mother into hypoglycemia. Immediately. Next, you tell them to stop two drugs which are common in diabetes. One of them is SCE inhibitors. Why are they used in diabetes, SCE inhibitors like enalapril? One of the physicians called Dr. Mandama Jr. told me they are renoprotective. I don't know whether it's true. They are renoprotective. Very important. Make sure you add the enalapril. But when I argued with him when we met, But no, as we don't use enalapril, because enalapril is too harsh for the baby, particularly the kidneys. At the same time, we also have to stop drugs which are like atorvastatin, simvastatin. What are these drugs used for? These are lipid lowering drugs, right? They are HMG-CoA synthase inhibitor. So these ones are used to lower the levels of lipids. But again, you find some diabetics are on this because they have type 2. So people think the fat levels are high. So in other words, you need to analyze this lady and say, okay, we are not saying what the physicians who read bigger books are doing are wrong. But in the time when you diagnose pregnancy, you have to stop. Why am I saying at the time when you diagnose? Do you think you know immediately that my client has become pregnant? Yeah, it will be them that will detect first. So they will know, this information would have already been given to them. So they will know that, I think the doctor mentioned, it's even written here in the paper where they were explaining to say these drugs we need to stop. Then lastly, start folic acid, high dose. What do I mean by high dose? 5 milligram OD per oral for 3 months before conception. Now, I mentioned last time when you did anemia in pregnancy to say these yellow tablets, are they yellow? They are yellow. Small tablets, 5 milligram, that's too high a dose because the dosage we did just for pregnancy is 0.4 milligrams. Now imagine from 0.4 you are giving 5 milligrams. But for sickle cell disease and diabetes mellitus, we use high dose. These are the few exceptions where we use high dose. The same applies to salbutamol. Do you know that that dose is too high? What's the dose of salbutamol? Eventually, it's 4 milligrams, is it? It's how much? 4 milligrams is too high. You see, but see, we find that most of our formulations are still working like that. So this is basically preconception management. Make sure you give your clients the contact number so that whenever the pregnancy is diagnosed by themselves, either with the drug index, which they could have done at home or elsewhere, they need to be ready. Now let's go to antepartum. And we start with fetal. I always prefer, of course I'm not saying you look at the baby separately, the mother separately, you'll visit them at the same time. But for you not to get confused, because diabetes mellitus is a big topic. I'm just trying to package it and make it a bit simpler to follow. So let's look at one aspect at a time. So when you are looking at this mother, first you say, let me concentrate on the mother alone. Then I'll concentrate on the baby alone, because you are looking at both individuals. So the first thing that you are going to do for the fetus is a dating and viability scan. This one should be done at 8 weeks or less. Very, very important. If there's one single scan which is very important in diabetes mellitus, it's a dating scan. Because you shall see that management depends highly on the gestational age. If you are dealing with a diabetic mother without proper dates, you are going to mismanage the patient. You might even lose the baby in the process. So make sure that you have accurate dates. Very important. Then, between this and another scan, there's another scan that we do. But between this, there is what is called first trimester assessment of fetal well-being markers. What do we mean by markers? This one is done between 12 to 14 weeks. What we are trying to say is that we need to check for what is called alpha fetoprotein, unconjugated estriol, beta HCG. Then there is another one known as the placental-associated plasma protein A. And lastly, there is what is called scan for neutral translucency. So somebody will tell you that these are summarized as triple, quadri, depending on the number, and the combined tests. So you can run through these parameters because what is our idea? Our friends try to stop a pregnancy at the earliest possible moment when there is a congenital malformation not compatible with life. If anything, even before you get there, if you go into ART technology, there is what is known as pre-implantation gestation diagnosis, PIGD. So remember when I was talking about fertilization, blastomere, morula, at the very moment when we know that mitosis has started, they get some cells and take them for analysis. Then they are able to tell, this pregnancy is not going to go anywhere, let us stop it. As early as that. But this could be somewhere around 12 to 14 weeks you can run these markers. Then you do what is called an anomaly scan. This one should be done between 18 to 20 weeks. Then after this scan, you need now to do what is called the serial scans or follow-up scans. So from, let's say 32 weeks, and this will be done 2 weekly. What are you interested in? Why are you doing these scans? One of the things you are looking for is growth. So you are looking for expected fetal weight plus LIQA, meaning either amniotic fluid index or deepest vertical pool. Because you know that there is risk of macrosomy, just like there is risk for IUGR. Now you see what I was talking about, to say you need to understand the complications for you to understand your management, because you cannot manage this mother like any other mother who is coming for antenatal. You should have complications in mind. So why are we checking for LIQA? Because of polyhydramnios. And sometimes you can make decisions just based on these two parameters. To increase, for instance, the dose of insulin because their fetal complications are rising. So very important. But also don't forget that these scans will also help us with the fetal well-being. Meaning the biophysical profile of Manning. There are many types of biophysical profile, but we normally use Manning's biophysical profile, which goes up to 10, where we look at the non-stress test, which is must to be reactive. We look at fetal gross body movements, fetal breathing movements, fetal tone, and then you also look at the LIQA. Yes, so together that makes the Manning score. You can, but you know that again, biophysical profile is not so accurate around this gestational age. Why? Because the autonomic nervous system of the baby is not well developed. No wonder I would also urge you to do what is called Doppler wave studies. These for me are very powerful, and this hospital prides in having this. We have them everywhere, almost on every machine we are doing, from the one we have in Nebawan, the one we have everywhere. We've got more than 8 machines. You can boast. But always request, because I've seen some of you don't request for Doppler waves. And our expert there is even sometimes surprised. Why don't these people request? Sometimes even does it on his own without even a request, because that's very important. What are we talking about? On Doppler waves, we normally use 2 arteries. One of them is the umbilical artery. of the baby or the ductus venosus. Remember, ductus venosus is the shunt which connects the umbilical vein to the inferior vena cava. There is a shunt there. Very important. Maybe we should talk about fetal circulation later on, because it's very interesting how blood moves in the inferior vena cava. The blood which is coming from the lower limbs of the baby moves slowly. It moves more along the walls. It's called preferential flow. The one which is very oxygenated from the mother through the ductus venosus moves in the center of the vein, and it reaches the heart faster before this other one reaches. Very interesting. Then the one which reaches first enters the right atrium, but does not go into the right ventricle. Instead, it moves into the right atrium and makes a shortcut, goes in the left atrium through the foramen ovale. Then what happens from the left atrium? It dips into the left ventricle through the mitral valve. Then left ventricle pumps through the arc of the aorta, the blood goes. So you see that the head and neck receives very nice blood. But I think the head and neck is not fair. It receives almost all the oxygenated blood, with only minimal mixing somewhere at the point at which the hepatic artery was discharging, but very minimal drop in the oxygen tension. Then remember the branches. We have the brachiocephalic trunk, which gives off the common carotid and the subclavian there. Then we have that other common carotid, and then the subclavian. So all these upper parts, they will receive enough oxygen. But what happens to that blood which was trickling behind? It also reaches the right atrium. Oh, can't you imagine? Ductus venosus. That one won't pass through the foramen ovale. It will go into the right ventricle. But where does blood go when you pump the right ventricle? It discharges going towards the lungs, also for oxygenation. But do you have the lungs? They are not open. So what will happen is that from the pulmonary trunk there, you find that the pulmonary artery cannot go to the lungs. So what will the blood do? It will make a shortcut and go directly into the aorta at the descending part, after all that nice oxygen. So now that's a very deoxygenated blood. And that's the one which will mix with the one which came from the ductus. And then they will mix there, and then it will proceed to go down. So you can see that the baby seems to have different oxygens at different parts of the body. Of course, that is a bit of summary, and then it will go now towards the common iliac. But remember, from which common iliac, what do you find? You find each one has an artery, one from the left, one from the right, and those are called umbilical arteries. Then they will go together with the umbilical vein. Umbilical vein is going into the baby, umbilical arteries are going out. And that's what we see in the umbilical cord. 2 umbilical arteries and a single umbilical vein. Now, of course, we need to look at the fate of these structures after the baby is born. What happens to them? Now, the issue here is, if you wanted to know what is happening to the baby, which of these 2 are important? Is it the umbilical vein feeding the baby, or the umbilical artery which is discharging from the baby? Which one can give you a better outlook of how the baby is behaving? It's umbilical arteries, because umbilical artery is very much connected to the behavior of the baby and the discharging from the heart. You get the point? No wonder we use, okay, let me summarize by just saying that we use the umbilical artery and the ductus venosus. Now there's another one we use known as the middle cerebral artery. Now middle cerebral artery is not usually used for clinical or routine clinical use. We normally use it when we are trying to use the Lyle's chart, when you look at the rhesus incompatibility and the mother is already sensitized. Remember, previously we were using what was called optic density photometry. Spectrophotometry. Yes, spectrophotometry. Where we used to do amniocentesis and then check the levels of bilirubin and then come up with a chart of zones. But now that is very invasive. People are now using middle cerebral artery and checking for what are called the multiples of medians, the MOMs. Again, if I say mom, you think of money. Minute of silence. So let me remove this one. Let's go to this. So there are some parameters we check, what is known as the SD ratio. That's what you will see Mr. Francis reporting on. Peak systolic and peak diastolic flow. Because the fetal heart has pumped, so they are able to see the flow in systole and in diastole. So there will be, if you look at the scan, it will give you such waves. It will give you a wave like that, a wave like that, a wave like that, a wave like that. Okay, so this will be diastolic, this is it. Diastolic, systolic, so you can have a ratio. I don't want to go into an assessment of fetal well-being because it's a topic on its own. So that's when we'll talk about interpretation of this. Then we'll also look at what is called pulsatility index or resistivity index, and so on and so forth. Like I said, the moms are normally used for middle cerebral. So think of that. Then the next thing you need to do is the fetal lung maturity test. Because, reason is because EFW is not a reliable parameter for determining possible lung maturity of the baby. It's misleading, it's a misleading parameter. So you need to make sure that you do proper fetal lung maturity tests. And which are those? I think we all know that the left sphingomyelin ratio should be 2:1 or greater than that. There is also what's called the form test. There is also what is known as the lamellar body count. These are the ones I'm remembering. Then there is also phosphatidylglycerol. So once Dr. Sungoko comes as a fetal-maternal obstetrician, just say, no, let me come and do. You even be putting on glasses to around. Yeah, and you won't be talking to people with a long coat. Can we do the form test and then review with results? Then dexamethasone or betamethasone has to be given at least between 32 to 34 weeks. You can even be repeating it every 2 weeks if you so wish, because we say that issues of lung maturity is very crucial in that. So basically that will be your antepartum management for the baby. Like you are thinking in that direction for the baby. What about the mother? We are about to conclude. I think I have the notes for this, so I can even have one. So for the mother, number one, multidisciplinary. So we need OBS people, midwife, we need nutritionists, we need endocrinologists, we need physio. These 1, 2, 3, 4, 5. Apologies, Dr. Amson, I forgot you. Neonatologists or pediatricians. You see, all these are important. So you need to have a team. Colleagues, we've got this lady, she's diabetic. Whether it's gestational, it's pre-existing, we need to sit down and see her properly as a team. But now, even in this team, there must be a team leader, and the team leader has to be an obstetrician for several reasons. Because the obstetrician is taking into account the baby. And that's why I don't believe in the issue of over-consulting. No, even in the file, it's a plan, awaiting endocrinologists to see. You come the following day, awaiting endocrinologist to see. What are you doing you yourself? Yeah, because the same endocrinologist will come and say, I want to prescribe glitazones. Can they be given in pregnancy? They'll throw back the challenge to you. Now for me, I'm thinking that this mother has to be put on this. So what is your view? You as the obstetric people again. Can we use these drugs? Can we do this procedure in pregnancy? So do you see that for you, you are supposed to be a bit more robust in your understanding? Of course, I'm not saying the endocrinologist is not important. There are some challenging situations where they can come in and advise. But ultimately, you have to be the team leader. Number 2. And then the other reason, and I'm sure you agree with me, if a patient will be seen by so many people at different times, you end up mismanaging the patient. Me, I've seen. I come, I see, oh, today's sugar is 12 point this. This is too high. I will increase the dose of insulin. I will put it at, from 12 international units, I'll put it at 16. I go. The other person is on call. Imagine the patient is in ICU or in HDU. Another group comes. Who put this 12? This is, now look, the sugar is 6. This is not correct. They change again from 16, they put it back at 12. They go. Then another person from another department comes. Who changed my plan? In that case, stop calling me. There you go. So at the end of the day, you have so many people changing. And that's not good for the patient. That's why for me, whenever I'm seeing a diabetic on the ward, I'll choose. I'll ask somebody who will just be dedicated at changing the dose. Maybe it will just be 2 people. Even me, I won't be able to change. Because I would rather somebody who understands the pattern and what is happening to take lead. Probably I will be involved in other aspects of management, but not adjusting doses. Because you will find there will be so much fluctuations in what you are doing. That's my opinion. Then, from multidisciplinary now, we go to, mind you, we are talking about the mother, right? We are on the side of the mother. So the first thing we need to do is repeat target organ damage screen. Remember, we said that we had the baseline at preconception. Now we are repeating it in pregnancy. Now, one of the things I forgot to tell you that you should discourage a couple from conceiving is not just the HbA1c, but also nephropathy. If there is evidence that the kidneys have already been touched by diabetes mellitus, don't conceive. Prognosis now for the mother will be poor. And that is why we have to repeat the target organ damage screen. The next thing that we are going to do is that you can do an oral glucose tolerance test, maybe at 28 weeks. I think I did not do, yes. If that is if you are suspecting GDM. Now, I didn't talk about GDM in terms of risks, because there are some people who already have some inherent risks. For instance, somebody tells you, the first pregnancy I had a big baby. I had a baby with congenital fetal malformations. I had polyhydramnios. You see? Then, or I had a sudden IUFD. You know, like these are warning you to say, this patient maybe can be a risk for GDM. They even tell you, in the family, my aunt even has diabetes. It's like a textbook fitting into a risk. But also don't forget, in current pregnancy, you find that glucosuria. Glycosuria is 4+. Okay, let me just start from 2+ and above. Because remember, it's normal to have a bit of glucose in your urine. Because of all those changes we are talking about, renal reabsorption, what and what, progesterone, and things like that. And the glomerular filtration rate. But it shouldn't be gross glycosuria. So, this put together makes diabetes to have two types of categories. Or in terms of risk, there's high risk and low risk. High risk and low risk. Yeah, and other classifications. Some classifications are fallen out of favor. Remember, we used to have what was called the Priscilla White classification. Very odd, taught by very odd obstetricians. You only find it in a book of obstetrics, the 2th edition. Very odd, 1920. I hope you are not reading those books. If you have those books, just discard them immediately. You are doing a research and in your citations, it's 1820. Mulenga et al. 1820. On it which I review. You'll be marked heavily downward. No matter how many pages. Okay. So we are saying we can do another glucose tolerance test because we really want to see whether this is glucose intolerance or is proper GTM. Now, next, I'm continuing on the antepartum. It's the infection. Remember, infections like UTIs and what are common. So here we want both surveillance and the prompt treatment, both of infection. So meaning that urinalysis is supposed to be mandatory every visit so that you're able to check for blood, for nitrates, for leukocytes, for proteins. I think these are the things you look out for so that if you find the significant leukocytes or these other parameters, what do? You treat with or without complaints by the patient. So you treat what's called asymptomatic bacteria. Next, preeclampsia. Again, you have to look out for it, meaning that every visit there must be a blood pressure reading, there must be a urinalysis to check for proteins. You are looking out for problems. Next, switch or start insulin. Now, insulin, we know that in first trimester we give 0.7 international units per kg body weight per day. First trimester. Second trimester, 0.8 international units per kg, that's second. And in third trimester is 0.9 to 1.0 international units per kg body weight, that's third trimester. So that's a guiding principle. It's just a guide. But you can't use it as a hard and fast rule. Now, away from that, you need to know that if it's a patient that has diabetic ketoacidosis or HHS, we all know. I'm not a physician, but I know if a patient came in DKA, what I remember, I was taught by the physician, Dr. Mandama Jr. I think he has taught me a lot. Dr. Mandama must have been my senior at medical school. What do you do in DKA? I thought the first principle is insulin. You give hourly insulin, right? You give hourly insulin. So let's assume we are giving insulin every hour IV. What dose do you normally give? Like an adult, an average? So like roughly what number in absolute figures? Is it 10? Is it 8? 7? Okay, 0.1. So if I'm 60 kg, you give me how much? 6? Okay. 60 kg, 6. I want to make my own plan because when I come with DK, I don't want people to change my plan. I will say this has been written for me by my physician. So 6 IV you are giving. What else are you doing? We know that you have to halve the dose of insulin, right? When you get to which sugar level?
15. Sometimes we say 15. That's 12.5.
Millimole per liter. You halve the dose. Okay. Then what do we do for fluids? We give which fluid? Normal saline, Menger's lactate, what? Normal saline. You give how much? The first letter has to run in what? I'm trying to remember. Because now that you've mentioned DKA. Okay, so let's all revise DKA, right? So we start with normal saline. You give very quickly, 30 minutes, 1 hour, 2 hours to 2 and 4. Then what do? We change the type of fluids when you reach a certain sugar from normal saline to DNS or 5% dextrose. What else? We start thinking of potassium replacement, maybe from the second liter. But again, if you are guided by ABGs, you will know the serum potassium and know whether to give or not. Not so. The role of bicarbonate is highly questionable, much as we expect that there is metabolic acidosis. And then don't forget to add an antibiotic while you do a full septic screen. Now the point is, in all this funny situation of DKA, you are looking at the total amount of insulin that has pushed the patient off DKA. Assuming you've got ABGs, I always keep talking about ABGs. So that once you check the anion gap, the bicarbonate, the pH, and you are convinced that this patient is ketonemia, this patient is no longer in DKA, what are you supposed to do? You add up all those insulin, and that will be like your requirement. And then how you will divide it, whether it's basal, I don't know what you people call. When I heard basal volumes, I thought it was like fertilizer. Because I heard that from one of the physicians. No, the basal dressing. No, not basal dressing, basal volumes. So why am I emphasizing about this is that the situation depends on what you are using as your basis for calculating the total requirement. Don't just go by 0.7, 0.8. You can adjust downwards or upwards. Now, away from that, let's look at the methods of insulin administration. We know that insulin, generally, in our setting, we have 2 types. We have what is called soluble, which is, the other name is what? Is actrapid. How does it look like if you want the patient to remember it? It's water, colorless. Then there is another one known as the lente. Lente is the protafen. And this one is cloudy. It's like milk. So if I'm dealing with a baby, if I was a pediatrician, and I'm starting that baby on insulin, I'll tell him, this one is milk, this one is water. They will know, at least. And then we have a combination of these two known as actrafen. What's the other name for actrafen? I've seen other trade names like Wosolin, something like that, eh? It's even written 70-30, because it's like they've already made the ratios. So you need to have these forms of insulin at the back of your mind. Now, how is it given? Now, one of the regimes is to give it as the soluble TDS, of course subcut, plus lente, which will either be OD at night, nocte, or BD. So you see something like soluble is 15, 15, 10, and then this one is I'm just giving an example. Maybe they'll put it at 6. OD or BD. International units. Now, this is good because it follows the physiological behavior of insulin in the body. But I've always argued that it's not user-friendly. Why am I saying it's not user-friendly? Because my client, who is a mother, antenatal, is a teacher. So if she's injected herself in the morning, she has to inject herself in the evening. So I don't know why she'll be keeping the insulin. Maybe at work, more free genes will be insulin. Like an insulin syringe, like a glucometer, and the glucose stick. Do you think that is user-friendly? You're at a party, birthday party, you need to inject yourself this one. And also, don't forget that this will be coupled by several readings. I've seen some of you who even ask for 4 readings in a day. So you're injecting yourself with the insulin, you're also injecting yourself with the glucometer. So it might be a bit inconveniencing, in my opinion. But there is another one So this one is liked by physicians like Dr. Mandamanjunga. Now me as a midwife, I like the BD regime. Now the BD regime is in the morning, you will give some soluble and lente, both. And in the evening, you give some soluble and lente. Meaning in between, you can do whatever you want. So it's just in the morning and in the evening before she sleeps. Okay. If you are lucky and this can be put in the form of actraphane, then you just have actraphane in the morning, actraphane in the evening. But I still like them to be separate entities before you control the sugar, because once they are combined in actraphanes, it's difficult, you can't separate the components. So if the sugar in the morning is high, the one in the night is normal. What are you going to do? But you can easily manipulate these separate entities, especially when you are on the ward. Once you now know that you've reached a steady state in terms of sugar control, then maybe you can consider sending them on the combined one. Now, this BT regime is given in phase. I can give an example. For instance, if I'm 60 kg and I'm in third trimester, what will happen is that I'll calculate, okay, let me use 1 international units per kg body weight. In fact, even when you write in your notes, you should write the basis to say the total dose is this based on this calculation, so that every person can look at how you came up with those numbers. Not so, Dr. Gasol, the anesthesiologist.
Yes, doctor.
Can you just be giving dopamine, drops per minute, just like that, without giving how you calculated it? It will be difficult for the other person to know, how did he come up with these numbers? Should I reduce, should I increase? So you say, total is this based on first trimester, 1 international units per kg body weight 60 kg. So somebody knows, oh, this is how they came up with this. Now, the total will be 60 international units per day. Now, this day has got 2. There is now you ask yourself, a day has got AM and the PM. So, of this 60, let me get 2/3. 2/3 of 60 is what? It's 40, international units. We wanted me to do 1, 2, 3, 4, then come to graph here. That is academic investment. Then this one will be 20 international units. So it means you will give 40 in the morning, 20 in the evening. Now, again, don't forget, we have to give both soluble and lente. So again, this 40, let us divide it. 2/3 of this and 1/3 of this. So 2/3 should be what? Should it be soluble or lente? 2/3, should it be soluble or lente? Soluble, right? Yes. I don't know if I can trust Dr. Mdamu. So 2/3 of 40 is what? It's like about what number? Mathematicians.
About 13.
It's 13.
That's 1/3.
1/3 is 13. Then this one?
About 26.
About 26. That's an estimate, right? So it's something like that. So this one will be soluble according to what I've been told. And then this one will be lente. Something like that. So that's how like you are coming up with numbers. And then this one, is it 2/3 and 1/3? It's half. So it will be 10 international units and this one will be 10 international units. So that is it, like how you come up with your numbers, roughly. Yes, I know it's not physiological. It's like what people say, chasing. It's like you're chasing the sugar. But in terms of being user-friendly, I think it's a bit more, because patient injects only twice. The last regime is this soluble, not soluble, insulin subcutaneous insulin infusion, pump. So you've seen how, for instance, we give the Jadel or Implanon. It's like you've inserted something and it's discharging, right? It's subdermal. Can we do the same for insulin? Our friends are complicated. They are thinking every day, how can we innovate something? How can we make it easier? I was just discussing with an endocrinologist who happens to be my big brother. Swedish. He's an endocrinologist, senior consultant. Works both at the United Arab Emirates, employed by the government there, but he has just gone back to Sweden. So I do ask him several times what they are doing as an endocrinologist. Sometimes even my heart pains. I even cry when I'm alone. Let's update ourselves with the latest information. But the point I'm trying to say is that we need to continue innovations. You can't tell me that the SIM speculum, which was developed by Professor Sims, is the best. Maybe you, over your work, over time, you would have said, I think the problem with SIM speculum is that it's too narrow in the size. Can I come up with something which is like a Morris retractor, but not really a Morris, because it's not this? And then you go and ask your colleagues who've done engineering or whatever other field. You call them in theater. Okay, of course, you can't call them in front of a patient. But to tell them, this is what I do in theater, and I'm trying to come up with something which can fit in this kind of space. I'm sure they can make for you. Is that possible, Dr.
It's possible.
It's possible. I'm mentioning that, and I know not to digress. One of my teachers, Professor G. Paham, Professor Paham asked a colleague who is not a medical doctor, but is good at, what do you call those things? When you wear like my glasses, you are seeing something, what's that called? Virtual reality. Tells him, this is how I do radical hysterectomies. Are you able to translate this into visual so that I can teach my students? And then professor looked at that, the other professor now, looked at that, analyzed it, and he gave him the program. So meaning that even us, we can do more innovations, because pricking yourself every day is not easy. So is there any other method you can use? Away from that, what should we do? Whenever we talk of insulin, we need to talk about counseling. Counseling on what? One, signs of hypoglycemia. So you tell them once you start feeling this, because this is a patient who was on oral hypoglycemic, so you're introducing a new drug. So they need to understand it from the beginning. So you tell them, whenever you start feeling weak, palpitations, sweating, we even tell the husband to say, if you see her becoming restless, touching this and that, know that the sugar is low. Give her a sweet. Make her a sugar solution, or give her a drink. Okay, so that is important. Then there is also what is called an evening snack. You know that, I don't know what time you have your supper, but most people maybe they might have supper around 20 hours, but I don't think they sleep at 20 hours. They might sleep at 22 hours. So before they sleep again, they eat something small, like a fruit, like they make a cup of tea with bread, okay? All you are trying to avoid is to have hypoglycemia in the night when somebody's asleep. And that explains why, if you've seen most of the regimes the physicians will come up with, they will try to reduce the dose or the evening dose of insulin so that you don't have the risk of hypoglycemia in the night. Then, the other thing you tell them is about the care of the skin sites, where they'll be pricking, alternating the sites. Then also you talk about storage of insulin in a cool place, and so on and so forth. So these are some of the counseling that you give. There is also what is called the Somogeo effect. I don't know if you remember it. Yes. So you need to explain all this so that they understand. The next thing is sugar monitoring. Again, we differ with a lot of people, because I've seen people who say, no, check for fasting blood sugar, check for pre-prandial, post-prandial. Now imagine you've got 3 meals in a day. Can you manage? Do you know the cost of those glucose sticks? But But of course, cost should not be an issue. But again, be practical in what you are advising. So I don't want to be misquoted, but me, I would just request for even 1 sugar reading per day or every other day. All I want is just to have some kind of a trend. Once I think that the sugar is well controlled, I can ask them to skip so that they just live a normal life as well. Because imagine that antenatal care is a long period. We're talking about 9 months. And somebody is every day pricking themselves, every day, checking for the sugar, and so on and so forth. So you can make it easier for them. But fasting blood sugar is very important and probably one of the random blood sugars, or just go for fasting. Next, we need to talk about nutrition or counseling. Now the nutritionist comes. And the nutritionist will come in to talk about DM diet. Again, remember, we said you don't need to over-restrict our mothers. So, for me, if they don't have brown bread, they can take white bread. That is not an issue. What is just important is whatever you are giving as nutritional advice should comply with science. At the same time, we can go to physio. What's the role of the physiotherapist? The physiotherapist has to advise for light exercise and lifestyle modification. It's only here in Zambia we don't take physio seriously in pregnancy. You know, some of the pain mothers have, like what they call side pains due to tension of the round ligament. When the progesterone level drops, they will be having pain along the course of the round ligament. Such type of pain, superficial pain, subtle pain, non-specific things, it's a physiotherapist. A physiotherapist doesn't just deal with exercise, do like this, do like that. No, they also deal with the pain management. So you can actually refer them to a physio. Finally, what are we saying? We are saying that we have to plan for admission. So when do we admit? I would advise that you admit at 36 weeks gestation. Then when you admit at 36 weeks, your mode of delivery, we would prefer you go for induction of labor at 38 weeks. Or if there is an obstetric indication, you can do a cesarean section. So very important, that plan has to be very clear. Now we go into intrapartum. We are almost concluding. Intrapartum. Now the woman has gone in labor. A fetal. So for the fetal, intrapartum, there is nothing much you do. It's just monitoring. So you do what's called continuous electronic fetal monitoring. I know we can't do a continuous electronic fetal monitoring, but we can do something closer. Remember, we have a CTG, we can do Doppler sonicate, you can even do PNAT if you're in a place where you don't have this, but you have to auscultate closely to make sure that the baby is okay. Or you can even do early rupture of membranes. Because if you don't have a CTG, sometimes just rupturing membranes will give you the state of the lipo. If it's clear, I think you are a bit safe. If it's meconium, then think twice about what you are doing. Maybe one needs to reduce the threshold for cesarean section. Okay, what about maternal? The first thing that you are going to do is transfer patients to high dependence units. Not necessarily intensive care and not acute bed, but in a high dependence unit. Number 2, you are going to secure IV access but you need 2 IV access. Why are you putting 2 IV access? It's because in one cannula you are going to set up what is called an insulin infusion. In fact, soluble insulin infusion. So if you don't have an infusion pump, here we put plenty of infusion pumps. I have to advertise this also. If you don't have, even you go manual now, manual calculation, like manual transmission vehicles, clutch and accelerator, balancing. Similar. So you can get, say, 50 international units of soluble insulin, then add it in 500 mils of normal saline. Then calculate now the drops per minute. But alternatively, you can use an infusion pump and deliver 1 international unit per minute of soluble insulin. So I don't know, depending on how your infusion pump is designed, you can just make calculations there and it starts running. Okay, but what about the other cannula? You set up a 5% dextrose fluid. Now this one, it can run or it cannot run. It can run or it cannot run. So you have a cannula there and you have infusion. This one is continuous. You don't stop it. But this one, you decide. How do you decide whether to run it or not? You'll be looking at the target. So by NICE guidelines, you find that the target has to be 4 to 6 millimoles, checked every hour. So you're checking the sugar every hour. Somebody's in intrapartum phase. They are in labor, for instance. Then your sugar should be between 4 and 6. This is called tight control. Because you can lose the baby even in intrapartum. The sugar just rises IFD. So you avoid that by making sure you are within. Meaning that if you check after 1 hour, the sugar is 2.5, you run the 5%. But that's insulin infusion continuous. And you wait for the next 1 hour. If you find that the sugar is very high, more than 6, maybe it's 8, what are you going to do? Obviously, you won't run the 5%, but you increase the dose of the insulin from maybe 1 to 2 international units. You see, so it's like you are playing around with the numbers. Next is you skip the morning dose of insulin plus breakfast. Don't give breakfast, don't give insulin. Now, it will depend on which direction you are going. If you go by induction of labor, obviously you start by assessing the Bishop score, you do a non-stress test, and then you decide which method you are going to use, whether you use the misoprostol, dinoprost, or whatever you use, oxytocin, or indeed you go mechanical. But you have to assess those and then you proceed with induction. What is important if you are going for labor? Painkillers, analgesia. If you can do epidural, better. If you can't do epidural, make sure you give pethidine or fentanyl, like we discussed, based on the cervical dilatation and the severity of the contractions, and then for the strength of the contractions, and obviously you can have naloxone, which is an antidote for opiates on standby. In fact, we are even safe because you have the neonatologist. So even if there's a problem, they'll handle that. Why don't we want pain? We don't want pain because pain will raise the catecholamines. And those things will now cause some changes in the sugar levels. Okay. What else? If it's cesarean section, it has to be the first case. First case. Don't keep a diabetic and you start dealing with a 2 previous Caesar, elective, and you leave the diabetic because you know that they haven't taken breakfast, they are on insulin, chances that they can go into hypoglycemia is very high. What is the mode of anesthesia? The best is regional or spinal anesthesia. Why? Because we want them to start eating immediately and to start bonding the baby immediately. But of course the baby won't be given to the mother. But you don't want them to remain like that. What is the end point? After delivery, be it by vaginal or cesarean delivery, you stop all the insulin. Now, when you stop the insulin, what do you do? Number one, you revert back. If it was a case of GDM, meaning this person was okay, maybe the sugar started at 28 weeks, at 30 weeks, what do you do? If it's GDM, you go to nothing. They will just be like that. If it was like they had pre-existing DM, then they go back to their what is called pre-pregnancy insulin dose, which is very low, which was given by the physicians. Or they go back to oral hypoglycemic. Initially, we were thinking, no, let us see, hold on a little bit and do what's called the soluble insulin sliding scale. But again, sliding scales are very debatable amongst the endocrinologists now. Like I was mentioning, chasing the sugar. There's even chasing the virus. Everybody does that. If you fail on third line ART, you might think of salvage therapy, for instance. But its effectiveness is questionable. Okay, so away from that now, we go for the baby. The baby we've already talked about, interpartum. So let's go to postpartum. So again, after delivery, you stop the insulin, what do? You continue monitoring the sugars and you keep in high dependency unit for the next 24 hours. Similar to cardiac. Postpartum, as we conclude. For the fetal, now it's no longer a fetus, the baby is born. Neonatal, just take to NICU. Again, NICU, there are those doctors, they're called pediatricians, I've seen them, very serious. They move with small stethoscopes. Not like this one, you see, this is a Rickman. Now them, it's like a third of this size. Very small, just here. They are auscultating for the fetal heart. Oh, it's not a fetus, right? It's a baby. They even put it, a little teddy bear there and the ribbon. So those ones are the ones who will tell us how to manage it. Me, I don't know. Then, for the mother, of which I'm interested in, the first thing that we are going to do is that we are going to give breastfeeding counseling, very important, because sometimes you might have reduced milk. Then we also do contraceptive counseling. In contraceptive counseling, you avoid estrogen. So give the mother options. Then also, remember, one of the problems we had for the mother was what? Puerperal sepsis. So you have to look out for signs and symptoms of puerperal sepsis. And finally, you do the oral glucose tolerance test at 6 weeks. Other people say 12 weeks. Because you want to know whether this gestational diabetes has gone complete or it has remained permanent. So you want to see the flip side of puerperia and see whether she's gone into overt diabetes or not. Don't forget, in all this, as I've already concluded, at delivery, when I went back to the mother there about the sugars and what, if you go by induction of labor and your aim is vaginal delivery, at delivery you have to have an experienced midwife and basically an experienced deliverer, because of two things. Remember, we talked about PPH due to atony and shoulder dystocia. So one who will remember the McRoberts maneuver, Rubin one, Manzanti, Woods corkscrew, and other funny maneuvers that we are teaching you that day. Who needs to be present. And also the neonatologist has to be present in the labor ward as well, or in the operating theater. We've ended.
Mm.